The following presentation is on Niaspan. The generic name is Niacin Extended Release Tablets. There will be two presenters for this podcast. My name is Todd Omrine, the first presenter. I am the training manager for the WellCall brand team. With me today is Carolyn Silverman. Carolyn?
Hi, as Todd said, my name is Carolyn Silverman. I will be your second presenter today. I am a registered dietitian and certified diabetes educator and the national manager for the WellCall Clinical Educator Program.
Thanks, Carolyn. Let's get started. This is for your information only and is only intended to be a summary of information relating to Niaspan. Do not use this information to make a comparison of WellCall efficacy or safety information to Niaspan, as no head-to-head studies have been performed with WellCall.
These are the 6 major classes of drugs affecting lipoprotein metabolism. Remember that the NCEP ATP3 algorithm emphasizes LDL-C lowering with statins first. After that, an HCP can choose to increase the statin dose or add on a second agent, such as Niaspan or WellCall. This presentation is on the only once-a-day extended-release prescription nicotinic acid available, Niaspan.
Niaspan is an extended-release, or ER niacin, which was approved by the FDA in 1997 and is marketed by Abbott Labs. There are 2 combination products on the market containing ER niacin. The first that came to the market in 2001 is Advicor, which is a combination of ER niacin and lovastatin. The second is Symcor, a combination of ER niacin and simvastatin, which was approved in 2008. Niacor is also a prescription nicotinic acid. Niacor 1 to 2 grams is immediate release, or IR niacin, and must be taken 2 to 3 times a day.
For individual products features of Niaspan, Advicor, and Symcor, I refer you to the individual package inserts. However, let's take a look at some of the key features of Niaspan, utilizing PADDOX, which stands for Pharmacology, Adverse Events, Dosing, Indications and Efficacy, Contraindications, and the supplied form. The mechanism by which niacin alters lipid profiles has not been well defined. It may involve several actions. Let's take a closer look.
Sometimes, a low-fat diet and exercise alone are not enough. Doctors may prescribe Niaspan, an extended-release niacin, along with diet to help raise HDL-C and lower LDL-C, triglyceride levels, total cholesterol, and ApoB in patients with abnormal cholesterol levels. Niaspan is also prescribed to reduce the chance of having another non-fatal heart attack in patients who have had a heart attack and high cholesterol levels. Niaspan is also indicated to slow the buildup or even help clear away some plaque that builds on artery walls when used in combination with diet and a bile acid binding resin in patients who have a history of coronary artery disease and high cholesterol levels. The mechanism by which niacin alters lipid profiles has not been well defined. It may involve several actions, including partial inhibition of release of free fatty acids from adipose tissue. This is important because elevated plasma levels of free fatty acids are associated with insulin resistance in skeletal muscle and in the liver, and may also play a role in the pathogenesis of coronary artery disease. Additionally, niacin may increase lipoprotein lipase activity, which may increase the rate of chylomicron triglyceride removal from the plasma. Lipoprotein lipase, or LPL, is a rate-limiting enzyme responsible for the removal of these triglyceride-rich lipoproteins, and it is also critical for the formation of HDL particles. Niacin also decreases the rate of the synthesis of VLDL and LDL-C in the liver, and does not appear to affect fecal excretion of fats, sterols, or bile acids.
Most common adverse reactions for Niaspan are listed here. The most common one is flushing, which occurs in 88% of patients. Flushing can be as mild as a tingling sensation on certain areas of the skin, all the way to a burning sensation which may be accompanied by a redness of the skin, which may also itch. Patients typically get flushing when starting therapy or titrating the dose, which is why a slow titration schedule is recommended. It is also recommended that patients taking Niaspan should take aspirin, which may ameliorate the flush. However, flushing can occur at any time. Other adverse reactions are elevations in glucose or hyperglycemia, hyperuricemia, which is gout, a kind of arthritis that occurs when uric acid builds up in the blood and causes joint inflammation, upper GI distress, hepatotoxicity, diarrhea, nausea, vomiting, pruritus, and cough. Niaspan is pregnancy category C. Niaspan comes in 500, 750, and 1,000 milligram tablets, taken at bedtime with a low-fat snack. The highest recommended dose is 2,000 milligrams daily. Therapy with Niaspan must be initiated at 500 milligrams at bedtime in order to reduce the incidence and severity of side effects, mainly flush, which may occur during early therapy and should not be increased by more than 500 milligrams in any 4-week period. Caution should be used when prescribing niacin with statins, as statins can increase risk of myopathy and rhabdomyolysis. Bile acid sequestrants have a high niacin binding capacity and should be taken at least 4 to 6 hours before Niaspan administration. Concomitant aspirin use may decrease the metabolic clearance of nicotinic acid. However, the clinical relevance of this finding is unclear. Niacin may potentiate the effects of ganglionic blocking agents and vasoactive drugs, resulting in postural hypotension. Postural hypotension is the state of hypotension or low blood pressure which occurs when patients upright themselves too quickly, either from a seated position or laying down. It seems to occur more commonly in the elderly, and typically when waking at night. The Niaspan labeling contains the following in the warnings and precautions section. Severe hepatic toxicity has occurred in patients substituting sustained release niacin for immediate release niacin at equivalent doses. Niaspan is indicated to reduce elevated total cholesterol, LDL-C, apoprotein B, and triglycerides, and to increase HDL-C in patients with primary hyperlipidemia and mixed dyslipidemia. Niaspan is indicated in combination with simvastatin or lovastatin to treat primary hyperlipidemia and mixed dyslipidemia when treatment with Niaspan, simvastatin, or lovastatin monotherapy is considered inadequate. It is indicated to reduce the risk of recurrent non-fatal myocardial infarction in patients with a history of myocardial infarction and hyperlipidemia. Niaspan is indicated in combination with a bile acid sequestrant to slow progression or promote regression of atherosclerotic disease in patients with a history of coronary artery disease and hyperlipidemia, as an adjunct to diet to reduce elevated total cholesterol and LDL-C in adult patients with primary hyperlipidemia. Niaspan is also indicated to reduce triglycerides in adult patients with severe hypertriglyceridemia. Its limitations of use include no incremental benefit of Niaspan co-administered with simvastatin or lovastatin on cardiovascular morbidity and mortality over and above that demonstrated for niacin, simvastatin, and lovastatin monotherapy has been established. Niaspan has not been studied in Fredrickson type 1 and 3 dyslipidemias. Efficacy will be discussed on the following slides. Contraindications of Niaspan include acute liver disease, active peptic ulcer disease, arterial bleeding, and known hypersensitivity to product components. Niaspan comes in the form of 500, 750, and 1,000 milligram tablets. In 2 randomized, double-blind, parallel, multi-center, placebo-controlled trials in patients with primary hyperlipidemia and mixed dyslipidemia, Niaspan dosed at 1,000, 1,500, or 2,000 milligrams daily at bedtime with a low-fat snack for 16 weeks, including the 4 weeks of dose escalation, favorably altered lipid profiles compared to placebo.
Throughout this presentation, we will highlight lipid responses to the 1,000 milligram dose of Niaspan, which is the maintenance dose of Niaspan. Here you can see that Niaspan 1,000 milligrams lowered total cholesterol 3%, LDL-C 5%, triglycerides 21%, Lp(a) 13%, ApoB 6%, and increased HDL-C 18%, and increased ApoA1 9% compared to placebo. Combined data from 3 placebo-controlled Niaspan studies in patients with primary hyperlipidemia and mixed dyslipidemia suggest that, at each Niaspan dose level studied, changes in lipid concentrations are greater for women than for men. You can see the effects of 1,000 milligrams of Niaspan here.
In a multi-center, randomized, double-blind, parallel 28-week study, a combination tablet of Niaspan and lovastatin, which are the components of Advocor, was compared to each individual component in patients with type 2A and 2B hyperlipidemia. Using a forced dose escalation study design, patients received each dose for at least 4 weeks. Patients randomized to treatment with the combination tablet of Niaspan and lovastatin initially received 500 mg, 20 mg once daily before bedtime. The dose was increased by 500 mg at 4-week intervals to a maximum dose of 1,000 mg, 20 mg in one half of the patients and 2,000 mg, 40 mg in the other half. The Niaspan monotherapy group underwent a similar titration from 500 mg to 2,000 mg. The patients randomized to lovastatin monotherapy received 20 mg for 12 weeks, titrated to 40 mg for up to 16 weeks. Up to a third of the patients randomized to the combination tablet of Niaspan and lovastatin, or Niaspan monotherapy, discontinued prior to week 28.
Results from this study showed that combination therapy decreased LDL-C, triglycerides, and Lp(a), and increased HDL-C in a dose-dependent fashion. This study also showed that LDL-C lowering with a combination tablet of Niaspan and lovastatin was significantly greater than that achieved with lovastatin 40 mg only after 28 weeks of titration to a dose of 2,000 mg, 40 mg. The combination tablet of Niaspan and lovastatin at doses of 1,000 mg, 20 mg, or higher achieved greater LDL-C lowering than Niaspan. Combination therapy achieved significantly greater HDL-C raising compared to lovastatin and Niaspan monotherapy at all doses. In addition, combination therapy achieved significantly greater triglyceride lowering at doses of 1,000 mg, 20 mg, or greater compared to lovastatin and Niaspan monotherapy. The Lp(a) lowering effects of combination therapy and Niaspan monotherapy were similar, and both were superior to lovastatin.
In a double-blind, randomized, multi-center, multinational, active-controlled 24-week study, the lipid effects of a combination tablet of Niaspan and simvastatin, which are the components of Simcor, were compared to simvastatin 20 mg and 80 mg in 641 patients with type 2 hyperlipidemia or mixed dyslipidemia. Patients entered one of two treatment groups. In Group A, patients on simvastatin 20 mg monotherapy with elevated non-HDL levels and LDL-C levels at goal per the NCEP guidelines were randomized to one of three treatment arms: combination tablet of Niaspan and simvastatin 1,000 20 mg, combination tablet of Niaspan and simvastatin 2,000 20 mg, or simvastatin 20 mg. In Group B, patients on simvastatin 40 mg monotherapy with elevated non-HDL levels per the NCEP guidelines regardless of attainment of LDL-C goals were randomized to one of three treatment arms: combination tablet of Niaspan and simvastatin 1,000 40 mg, combination tablet of Niaspan and simvastatin 2,000 40 mg, or simvastatin 80 mg. Therapy was initiated at the 500 mg dose of combination tablet of Niaspan and simvastatin and increased by 500 mg every 4 weeks. In Group A, the primary efficacy was a comparison of the mean % change in non-HDL levels between the combination tablet of Niaspan and simvastatin 2,000 20 mg and simvastatin 20 mg groups. And if statistically significant, then a comparison was conducted between the combination tablet of Niaspan and simvastatin 1,000 20 mg and simvastatin 20 mg groups. In Group B, the primary efficacy was a determination of whether the mean % change in non-HDL in the combination tablet of Niaspan and simvastatin 2,000 40 mg group was non-inferior to the mean % change in the simvastatin 80 mg group, and if so, whether the mean % change in the non-HDL in the combination tablet of Niaspan and simvastatin 1,000 40 mg group was non-inferior to the mean % change in the simvastatin 80 mg group.
In Group A, the non-HDL-C lowering with combination tablet of Niaspan and simvastatin 2020 and combination tablet of Niaspan and simvastatin 1020 was statistically significantly greater than that achieved with simvastatin 20 milligrams after 24 weeks. In Group B, the non-HDLC lowering with combination tablet of Niaspan and simvastatin 2040 and combination tablet of Niaspan and simvastatin 1040 was non-inferior to that achieved with simvastatin 80 milligrams after 24 weeks. The combination tablet of Niaspan and simvastatin was not superior to simvastatin in lowering LDL-C in either Group A or Group B. However, the combination tablet of Niaspan and simvastatin was superior to simvastatin in both groups in lowering triglycerides and raising HDL.
Niacin's ability to reduce mortality and the risk of definite non-fatal MI has been assessed in long-term studies. This slide discusses 3 of those studies from the Niaspan PI. The Coronary Drug Project, or CDP, published in JAMA January 27, 1975, was designed to assess the safety and efficacy of niacin and other lipid-altering drugs in men 30 to 64 years old with a history of MI.
Over an observation period of 5 years, niacin treatment was associated with a statistically significant reduction in non-fatal recurrent MI. The incidence of definite non-fatal MI was 8.9% for the 1,119 patients randomized to nicotinic acid versus 12.2% for the 2,789 patients who received placebo. Total mortality was similar in the 2 groups at 5 years, 24.4% with nicotinic acid versus 25.4% with placebo. At the time of a 15-year follow-up, there were 11%, 69, fewer deaths in the niacin group compared to the placebo cohort, 52% versus 58.2%. However, mortality at 15 years was not an original endpoint of the Coronary Drug Project. In addition, patients had not received niacin for approximately 9 years, and confounding variables such as concomitant medication use and medical or surgical treatments were not controlled.
The Familial Atherosclerosis Treatment Study, or FATS, was published in the New England Journal of Medicine in November 1990. FATS included 146 men ages 62 and younger with apoprotein B levels greater than or equal to 125 milligrams per deciliter, established coronary artery disease, and family histories of vascular disease. Assessed change in severity of disease in the proximal coronary arteries by quantitative arteriography. Patients were given dietary counseling and randomized to treatment with either conventional therapy with double placebo or placebo plus cholesterol if the LDL-C was elevated, lovastatin plus cholesterol or niacin plus cholesterol.
In the conventional therapy group, 46% of patients had disease progression and no regression in at least one of 9 proximal coronary segments. Regression was the only change in 11%. In contrast, progression as the only change was seen in only 25% in the niacin plus cholesterol group, while regression was observed in 39%.
The Cholesterol-Lowering Atherosclerosis Study, or CLASS, published in JAMA, December 1990, was a randomized placebo-controlled angiographic trial testing combined cholesterol and niacin therapy in 162 non-smoking males with previous coronary bypass surgery. The primary per-subject cardiac endpoint was global coronary artery change score.
After 2 years, 61% of patients in the placebo cohort showed disease progression by global change score, N equals 82, compared with only 38.8% of drug-treated subjects, N equals 80, when both native arteries and grafts were considered. Disease regression also occurred more frequently in the drug-treated group, 16.2% versus 2.4%.
The HDL Atherosclerosis Treatment Study, or HATS, published in the New England Journal of Medicine, November 2001, was designed to assess whether the use of lipid-modifying and antioxidant therapy would provide independent and additive benefits for the patient with CAD and low HDL-C levels. The background for this study was the evidence from epidemiologic studies that reductions in LDL-C and increases in HDL-C reduce the risk of cardiovascular disease, and the hypothesis that a low HDL-C level may reflect an antioxidant deficiency. HATS was a 3-year double-blind placebo-controlled trial conducted in 160 patients with coronary disease, low HDL-C levels, normal LDL-C levels, and triglyceride levels less than 400 milligrams per deciliter. Patients were randomized to receive one of the following: simvastatin plus niacin, antioxidants alone, simvastatin plus niacin plus antioxidants, or placebo. The primary endpoints included arteriographic evidence of a change in coronary stenosis and the occurrence of a first cardiovascular event, defined as death from coronary causes, MI, stroke, or revascularization.
Mean levels of LDL-C were reduced by 41%, and mean levels of HDL-C were increased by 25% in the simvastatin plus niacin group. The mean levels of LDL-C and HDL-C were unchanged in the antioxidant group. While therapy with simvastatin plus niacin resulted in an increase in the more protective subtype of HDL and HDL2, this effect was lessened by concurrent therapy with antioxidants. The average coronary stenosis progressed by 3.9% in the placebo group, 1.8% in the antioxidants group, 0.7% in the simvastatin plus niacin plus antioxidants group, and regressed by 0.4% in the simvastatin plus niacin group. The rate of first cardiovascular events was 24% in the placebo group, 21% in the antioxidant group, 14% in the simvastatin plus niacin and antioxidants group, and 3% in the simvastatin plus niacin group. This represented a 90% reduction in the simvastatin plus niacin group compared with placebo. The authors of HATS concluded that simvastatin plus niacin provides clinical and angiographically measurable benefits in patients with coronary disease and low HDL-C levels. The authors found no justification for the use of antioxidant vitamins in this setting.
Thus, it was a surprise to many clinicians when Niaspan failed to provide incremental clinical benefit in the National Heart, Lung, and Blood Institute-sponsored AIM-HIGH study, which stands for Atherothrombosis Intervention in Metabolic Syndrome with Low HDL, High Triglycerides, Impact on Global Health Outcomes. Although scheduled to end in December 2012, the Safety Monitoring Board ended the AIM-HIGH trial early, in May 2011. The final analysis, niacin in patients with low HDL cholesterol levels receiving intensive statin therapy, authored by the AIM-HIGH investigators, was published in the New England Journal of Medicine online on November 15, 2011. AIM-HIGH was a multi-year, randomized, double-blind trial involving 3,414 participants aged 45 years or older with established cardiovascular disease, defined as documented stable coronary heart disease, cerebrovascular or carotid disease, or peripheral artery disease. Eligible patients had low HDL-C, less than 40 milligrams per deciliter for men, less than 50 milligrams per deciliter for women, elevated triglyceride levels, 150 to 400 milligrams per deciliter, and LDL-C levels less than 180 milligrams per deciliter if they were not currently taking a statin. In the niacin plus simvastatin arm, patients received extended-release niacin, Niaspan, dosed at 1,500 to 2,000 milligrams per day, with simvastatin titrated to achieve a target LDL-C level of 40 to 80 milligrams per deciliter. In the placebo plus simvastatin arm, placebo contained a small dose, 50 milligrams, of immediate-release niacin to mask the blinded treatment. The simvastatin was again titrated to achieve the targeted LDL-C levels. In addition, patients in either arm could receive ezetimibe, Zetia, 10 milligrams per day, if needed to achieve the LDL-C goal. The primary study endpoint was the composite of the first event of death from coronary heart disease, non-fatal MI, ischemic stroke, hospitalization for greater than 23 hours for acute coronary syndrome, or symptom-driven coronary or cerebral revascularization.
At 2 years, Niaspan therapy had significantly increased the median HDL cholesterol level from 35 milligrams per deciliter to 42 milligrams per deciliter, lowered the triglyceride level from 164 milligrams per deciliter to 122 milligrams per deciliter, and lowered LDL cholesterol from 74 milligrams per deciliter to 62 milligrams per deciliter. An interim analysis plan had provided specified boundaries with statistical definitions for stopping the AIM-HIGH trial early, either for demonstrated efficacy or lack of efficacy. On April 25, 2011, the Safety Monitoring Board recommended stopping blinded intervention early due to a statistically documented lack of efficacy and an unexpected higher rate of ischemic stroke among niacin-treated participants. The primary endpoint occurred in 282 patients, 16.4% of the niacin group, and 274 patients, 16.2% of the placebo group. Among the components of the primary endpoint, there was an unexpected imbalance of ischemic stroke as first event, occurring in 27 patients, 1.6% of the niacin group, versus 15 patients, 0.9% in the placebo group. The number of patients who died from cardiovascular causes was low in both groups. In the paper's discussion, the authors point out that the lack of reduction in the primary endpoint over the 36-month follow-up period occurred despite the fact that the niacin plus simvastatin group achieved significantly better increases in HDL-C and reductions in triglyceride levels than the placebo plus simvastatin group. Commenting on the ischemic stroke rates, they noted that no previous studies or meta-analyses have shown increased incidence of stroke with niacin in any therapeutic formulation, dose, or dosing regimen. Interestingly, the authors note that 94% of patients were already taking a statin when they entered the trial, and 20% had previously taken niacin. The authors speculate that evolution of medical treatment, including disease-modifying therapies such as antiplatelets, beta blockers, and renin-angiotensin system inhibitors used in this and other trials may make it difficult to demonstrate incremental clinical benefit in trials with additional lipid-modifying therapies. An accompanying editorial in the New England Journal of Medicine echoes this. In other words, with increased use of baseline therapies that reduce risks, there may only be so much risk reduction to be demonstrated. While ad hoc analysis of the data continues, the paper notes that 3 different ongoing trials of niacin with other agents are underway in patients with cardiovascular disease, including the Heart Protection Study 2, treatment of HDL to reduce the incidence of vascular events. After diet and exercise, statin therapy remains the gold standard for treatment of hyperlipidemia and is often chosen as first-line therapy due to efficacy and strength of data on clinical outcomes. Many patients cannot achieve NSEP-ATP3 lipid goals on a statin alone, or cannot tolerate statin therapy due to elevated liver enzymes or myopathy, especially at higher doses. There are FDA concerns about higher doses of some statins like simvastatin. Niacin, ezetimibe, or bile acid sequestrants such as Welchol can be added to statin therapy to get patients closer to their lipid goals. The effect of Welchol on cardiovascular morbidity and mortality has not been determined. Remember, Welchol was not included in any of these studies. Welchol is indicated to lower LDL-C, but has not been shown to impact CHD. You can find more information on Niaspan, as well as Advocor and Semcor, by visiting the Welchol Resource website, where you will find the 2-page summary fact sheets, the online CAT, various training bulletins, the Meet Your Marketplace guide, the Welchol Home Study binders, and the package inserts. Thank you.